Thanks, Bridget. Good morning, everyone. So I have to follow that very visionary presentation with something very practical. Yesterday we talked about the experience of Namibia in applying the workload indicator of staffing need methodology developed by WHO. And in this session I will talk a little bit more about that methodology and how the results can be used. As a reminder, yesterday we mentioned that in Namibia there was a 300% increase in the volume of commodities that were passing through the central medical stores over a 10-year period, but very little changes in the staffing over that period. So either that facility became extremely efficient at dealing with those commodities, or the workload on the staff increased significantly. And a way to look at that, analyze it, and answer that question is to apply WISN. So we've been talking a lot about leadership during this conference, and so here is a sort of a vision of human resources management and what we'd like to achieve, which would be the right number of people with the right skills in the right place, at the right time, with the right attitude, doing the right work, at the right cost, with the right work output. So that's really a big challenge. WISN cannot ensure that all of those requirements are met, but it can help estimate how many staff of a particular category are needed at a facility given the current workload. I won't go through everything on this slide because I'm going to talk about those things later, but just to say that it also helps to compare staffing between different facilities. So if you have two regional medical stores, they may actually have different staffing needs depending on the workload. And it also helps to understand and assess the pressure and the distribution of workload among staff. So the WISN methodology is applicable to all types of personnel categories. In fact, it was originally came from business and industry. It's simple to operate, simple to use, acceptable and easily understood by managers and decision makers, and provides very practical information for budgeting and resource allocation. The results can be used to improve the distribution of current staff, reduce workload pressure, plan for future staffing, and redistribute tasks among staff, all with the aim of increasing the quality of services. Now, looking at the plan for future staffing, in health services, many of you might be familiar with staffing norms where if you have a certain kind of facility, there may be a staffing norm to have 2 doctors, 3 nurses, a pharmacist, etc. You can't be assured that that staffing norm is based on any kind of workload assessment. A lot of times these staffing norms are just sort of, a norm across facilities and not really looking at the workload or the service needs of that particular context. So WISN will actually help you to develop staffing norms based on evidence. To implement WISN, 3 groups are recommended by WHO. First of all, a steering committee of senior level people with authority to influence decision making and that can guide the implementation of the study and then decide on how to use the results. Then a technical task force which implements the study and analyzes the findings, and expert working groups that provide inputs to key steps in the process, such as defining activity standards. The steps in the process involve, first of all, deciding which cadres and facilities to study, then looking at the available working time of staff, especially looking at absences and leave time and making sure that those are factored in, defining the core activities or components of daily work, and then the time needed to perform each of those activities. And that's one of the most challenging processes, is actually getting people together to reach consensus on the time needed to do certain tasks. Then the group needs to establish the amount of these activities a staff member, a full-time staff member, can do in a year, along with other non-core or support types of activities. And finally, based on the actual or estimated workload at the facility, one would calculate the number of staff needed. Now, another challenge is actually to collect some of this data. Sometimes it's very difficult to know the workload required. In a health facility, you can look at the data in health information systems. I would imagine there is data as well in the logistics area and the supply chain management area, where you're looking at the volume of certain kinds of medicines or commodities and estimating the amount of time it would take to treat those types of commodities. So the calculations can be done manually, which increases understanding of the method. And in fact, in Namibia, where it was applied, I'll explain later, we actually did the calculations manually first, and then we used the WISN software just to validate the findings. Of course, the WHO WISN software speeds up data processing and is obviously more efficient in large studies. And I put the link there to the WISN manual and case studies and software on the WHO website. So here's just sort of a diagram to show what kind of inputs need to go in to the process and what kind of outputs you can expect. Again, the types and numbers of staff required, the workload pressure, which is expressed as a WISN ratio, the difference between available versus needed staff, and then the financial implications of increasing or decreasing staff, of redistributing tasks among staff, or even creating new categories of staff. So two of the key outputs are the difference, which will tell you the level of shortage or surplus at a facility, and the ratio, which tells you the pressure, the workload pressure. So if your ratio is 1, it means basically that you have adequate staffing. If it's less than 1, you have a shortage of staffing, and if it's greater, you have a surplus. So for example, if we look at the first row of this chart, you can see that for the cadre of midwives in Health Center A, currently they have 2 staff, but based on the workload, they actually need 4. So they have a shortage of 2 staff. And the WISN ratio is easy to calculate here. It's 0.5, which means that the workload pressure on those 2 staff is quite high. In Namibia, WISN was applied nationally to 4 cadres of workers, to doctors, nurses, pharmacists, and pharmacy assistants, and we talked about the results with the pharmacist yesterday, across 4 levels of public health facilities. And this is an example of how the results are being used. They're being used to increase the number of posts in the system, to redistribute staff from facilities that have too many staff to those that have shortages, to make decisions about shifting certain tasks from one type of staff to another, and also creating a new cadre of staff of clinical officer. They're also being used to help inform the development of pre-service education programs so that the right kinds of workers are being produced. And then finally provide feedback to the various health information systems, which apparently there are over 50 in Namibia, to explain what kinds of data were helpful and useful and what kind of data are actually missing in the system. So in conclusion, WISN, we found through our experience in Namibia, is a very powerful tool for needs-based workforce planning. It can be used to establish a baseline of staffing needs, and then it can also be used over time as workloads change to input new information and generate new estimates of staffing needs. Thank you.